Hi, everyone. Thank you for joining us today on this digital learning expedition about collaboration for better health. My name is Florian Mollard-Coulon and I'm the head of media partnerships here at Sparknews. So just for you to know, Sparknews is a French social enterprise working with journalists to dig deeper into major challenges by also looking at how people respond to these issues and how they have a concrete positive impact around them as well as elsewhere in the world. So, of course, journalists play a critical role in portraying these challenges. And we've seen for the past few months that your work has been more than essential, not only to keep citizens well informed about the progress of the pandemic, you've also given us the keys to go through it by informing us on how to protect ourselves from the virus and how to read through the decisions made by our leaders to fight the crisis, and also by reporting on stories that give us hope. Now, with this webinar, we hope we can help you in this colossal task and give you the necessary tools to look at the current health crisis, what it implies, what comes out of it, and what it could mean for the future of healthcare. That's why we've been working on with the Making More Health initiative to set up this webinar. To explore together the concrete collaborations that emerged during the pandemic and whether the model could be a solution for health tomorrow. But before going any further, I'll let Manuela Pastore, who just showed up on the screen, and who is also the global manager at Making More Health, to tell you more about this initiative. Hi, Manuela.
Hi, Florian. Thank you, and a warm welcome to all of you. My name is Manuela Pastore. I'm the global lead of the Making More Health initiative. It's an initiative that focuses on social entrepreneurship, and we have launched that as Boehringer Ingelheim, this huge pharmaceutical company, in 2010 because we thought we have to do something innovative, social, and also to look into more in social entrepreneurship. And we have started right at the beginning in 2010, the collaboration with Ashoka, and have built up a network of more than 100 social enterprises, Ashoka fellows who now closely work together with us in our initiative. And with this initiative, we have invested a lot in health projects and activities and have worked with partners of many different backgrounds, not just with social entrepreneurs. They are, of course, a focus of our work, but also we run our own let's say, activities in some project areas all over the world, with 2 focus areas in Kenya and India. And there we work, as I said, with social enterprises, but also with NGOs, with local partners, with government, with academia, and also with some other companies. And we believe that for making more health happen, we have to look more at the whole system, which means health depends also on income generation. If people have no money, they cannot care for health. It's also income generation. It's all about income generation for these communities we are working with. It's about infrastructure as well. Without infrastructures, if you don't have wash basins or toilets, it's also difficult to keep hygiene, even if you get, and we run a lot of trainings here. It's also about education. It's about empowering people with a lot of skills that regard health, hygiene, but even beyond, which means also, for example, basic business skills, digital skills, all these kind of different skills. And because we have learned a lot during these 10 years and seen the complexity that relates to health, we are looking now to open up, to not just to share what we do, but mainly also to invite others, other companies, other organizations from all sectors, also NGO and industries, really to co-create with us. This is definitely key to us. And with these words, I just stop here because it's your hour and Sparknews will lead you through the rest. Thank you so much.
Thank you, Manuela. And yes, as you said, it's your hour. Well, it's mostly your hour attendees. Just a reminder, all along the next 90 minutes, you please feel free to ask your questions or address your concerns in the chat directly in the question section, and to upvote the questions that you think are the most relevant. We really want this webinar to be full-on interactive, and you can't see them, but the Sparknews team is here with me to make sure that this really happens. So after our roundtable, you'll have the opportunity to meet with 3 inspiring entrepreneurs who have successfully put collaboration at the heart of their activity. We'll facilitate the debate for you to be in a position to discuss and ask direct questions to each of them, of course. But for now, to introduce our speakers and to moderate the conversation for the next 30 minutes, I'm very proud to introduce you to Andrew Jacobs. Andrew is a health and science reporter for the New York Times and has been reporting from various places around the world, such as Beijing and Brazil. But today, Andrew is here with us, reporting directly from, where are you, Andrew?
I'm in upstate New York, about 2 hours north of New York City.
Cool. Well, thank you for joining us, Andrew. Thank you for being here and hosting this roundtable. Before actually jumping into the topic, I have a question for you. How is the COVID-19, the current pandemic, affecting your reporting as a health journalist?
Well, it's been pretty profound in that I'm used to, as a reporter, going out and meeting people, just talking to people and seeing things in person, face to face. And the pandemic has really prevented me from leaving this chair where I'm sitting now. So in that sense, it's been challenging to kind of report out stories and to give it that kind of human touch, and the color that I think readers react well to. Stories that don't have that sense of humanity are sometimes a little flat. So that's been kind of a struggle. On the other hand, people are, this is sort of a positive, I think people are much more willing to talk to me, give me their cell phone numbers, people who sort of high profile, powerful people. It's easy to get in touch with them. It's easy to find time with them because everyone's just sitting down in a chair like I am, and they're generally kind of available. So I think it's sort of a double-edged sword. But I would say mostly I'm looking forward to kind of getting out there and traveling and seeing what's happening in the realm of global health.
Okay, yeah. And so this webinar will be mostly about collaboration between different sectors in health. And I was wondering if, despite your forced immobility and the issues you had with reporting, did you see any striking forms of collaborations or innovations within the US or elsewhere in the world?
Actually, it's a good question, and that is a really sort of encouraging thing that's happened very early on in the pandemic, in both this country and all around the world. You saw all kinds of people, ordinary people, academics, scientists, just tinkerers coming together and trying to deal with a very immediate crisis, which was the lack of PPE. And also the sort of perceived at the time, we were all worried about a shortage of ventilators. And so what you saw is just people, science students, people with 3D printers, factory owners, all kinds of, and government really coming together to try to make, for example, face masks or face shields, or different, gloves, things like that. And there was an extraordinary kind of rush of collaboration, and that was really encouraging. I think it made a difference, especially in hospitals. In those first few months in this country, we had a serious shortage of all kinds of equipment, and ventilators, for example. People invented these valves, 3D plastic valves that could split a ventilator into two, so two people could be sustained on one machine. You saw a huge number of people producing face masks that were really welcome because we had a serious shortage here. So I do think that the pandemic helped break down barriers and sort of eased. There's sort of always a competitive thing going on in health product industry. And I think here you saw sort of the breaking down of that barrier that had people cooperate instead of competing with each other. And then the FDA, the Food and Drug Administration, which is our sort of regulatory agency here in the US, they really lowered the barrier to kind of giving approvals for a lot of these products. They sort of, just eased it a bit, so to make it happen quicker. So I think it was pretty extraordinary, and it's still ongoing. And I think we'll hear hopefully today from our participants here about how they think the pandemic has changed what they do and how maybe it hasn't.
Yeah, and that's actually a very good introduction to the roundtable that follows. So I'll leave the floor for the moment, and I'll let you introduce our speakers to actually discuss this case, if you don't mind.
Sure. So we are joined by Dr. Maria Freire, who is the President and Executive Director and a member of the Board of Directors for the Foundation for the National Institutes of Health, which is an independent entity that helps raise money and supports the FNIH, which is an agency here in the US. And then we have also Moka Lantum, who is he created an app called iSitCure, which allows patients to instantly find out the price and availability of medicines and health products in local pharmacies. And I'm looking forward to hearing about that. But it's a technology that supports low-wage workers in Kenya and South Sudan and helps them have access to healthcare. And then Thomas Landrain, who's the co-founder and president of Just One Lab, and we'll hear more about this. I won't go on too much longer, but let's start with our speakers, and maybe you can, maybe Dr. Freire, you can tell us a bit about what you've seen happening with the pandemic and how has it affected what you guys do?
Well, thank you, Andrew, and thank you for the invitation from Sparknews to be here this morning. Well, it certainly has been a bit of a wild ride, hasn't it? And it's particularly important because of all the lives that are at stake. It's something that affects everybody everywhere. We see the pandemic, as you said, Andrew, earlier, of bringing people from very different perspectives to work together and have a laser sharp focus on what needed to be done. Let me tell you a little bit about who we are so that you can understand what we've done. We are an independent foundation that was created by the Congress of the United States to support the National Institutes of Health. And NIH is one of the largest supporters of biomedical research in the world. But as a federal agency, the degrees of freedom under which they work appropriately are different than the degrees of freedom that a foundation has. So we can do things and help the NIH in its mission that the federal agency cannot do. And one of the things we can do is convene different partners. In March 22nd, which was a Sunday, I got a call. I was in Peru, which is where I'm from, and I got a call from Francis Collins, the head of the NIH, who said, Maria, we have to do something. Can the foundation help us bring partners together? Because as you said, Andrew, what we were finding is that people were trying to help and doing many, many things. But when you were looking at vaccines and when you're looking particularly at therapeutics, you needed to have a concerted approach. So Francis brought together the Foundation for the NIH. We brought together 8 government agencies, including the European Medicines Agency. We brought in 20 industry partners and 4 non-for-profits, and we created what is called ACTIVE. And the mission of ACTIVE is to develop a coordinated research response to developing COVID treatments and vaccines. And we've been working for the last few months in getting that done. Vaccines were started earlier, so they were on their way when we began. But therapeutics were really at an earlier stage. So what we've done is we've created a collaborative framework for all of these groups to come together. We've helped prioritize candidates for therapeutics that will go into clinical trials. We've looked at infrastructure so that everybody can have the same platform and work together. And we've established large-scale, identified where the large-scale clinical trials could be. So it's a massive, massive effort in trying to move together the technology. So that's sort of what we've done and what we've seen.
Awesome. And Moka, would you mind telling us sort of about how the pandemic has sort of changed what you guys do, and also tell us a little bit about what you do?
Sure. Thanks, Andrew, and pleasure to meet everyone. I think Maria's points could not be overemphasized, that the chaos, societal chaos that occurred with the surge of new cases is one that, has forever changed the nature of conversations between organizations. Now, for us as primary healthcare providers using technology-enabled strategies, it was something that we couldn't anticipate how the pandemic could have a very positive impact on adoption of technology. And so we've seen a very rapid shift in the stakeholder engagement around the role of technology and healthcare. Before the pandemic, you would go to meetings and talk about software solutions for the masses. And you had questions like, well, have you thought about data privacy? Have you thought about access to mobile phones? So a lot of the bottlenecks, so people were seeing reasons why technology could not be easily applied. 2 weeks after the pandemic, everybody's looking for a technology solution provider in healthcare to say, how can we partner with you to establish a modality to increase access to information, access to consultations, and obviously access to treatment. And to a certain extent, now we're seeing access to testing. So the nature of the collaborative conversation has changed fundamentally. Now, in my opinion, from a global health perspective, I would love to offer a framework that says the global health agenda has been positioned in checkmate. The global health agenda was one where it took 6 to 9 months to move a simple decision. You required a lot of evidence-based approaches to create solutions. You required all stakeholders to sit at a table in order for decisions to be made. And more importantly, the framework in which global health was seen was that you have to coalesce resources around public health institutions, dispensaries, health centers, and district hospitals, which by definition are places where people congregate in masses, sitting shoulder to shoulder, butt to butt, waiting for hours on end in order to see a healthcare provider. And the message up till March was that get as many people in villages, in towns, to those locations, because that is where healthcare is offered. Come the pandemic, that location called the public healthcare setting is no longer safe. Now we need to think about redistributed systems for healthcare. And so in going back to the conversation that Maria had with the vaccines, the question is, are we going to even think about distributing vaccines as we used to do it in public facilities, where you had 100 mothers come for vaccination? Is that safe? Or are we going to think about how do we get vaccines to homes and look for ways to empower solution providers who are able to get into the homes? First question. Second question is, are we going to look for new partners in the collaborative ecosystem? Before the pandemic, partners were the Ministry of Health, the international NGOs, who had a lot of equipment and logistics, and you had public healthcare policymakers. Those were the key players who sat around the tables to drive decisions on issues such as malaria, HIV. Now with the pandemic and people staying at home, whereby the testing is orders of magnitude more expensive, and most public facilities do not have the testing for PCR testing, what ways, who are the new players do we need to bring on board? And I'd love to kind of suggest that there is a new need for collaborative partners. In our case, we have partnered with writers. And I use that as an example whereby we found that freelance writers are the main people who understand the community game. They understand when people need healthcare. They understand where the houses are and which people are. So we've partnered with them. And between April and now, we've gotten to over 35,000 homes. And we've delivered medicines to over 1,000 families. And those types of collaborations where you're collaborating with neighborhood groups, with rider associations, those in my mind are the new types of collaborations that we need to embrace. And then lastly, we need to look at the supply chain. Before the pandemic, it was a north-south supply chain. Vaccines from US, America, medicines coming from Europe into Africa. Right now, I would say the last 6 months, we are quasi-dependent on the south-south trade. And so you have to now think about processes of product registration, introducing new products to market, which are 10 orders of magnitude cheaper than what we had in the past. China and the South Asia Peninsula saved us with PPEs. Now we have to go beyond that and say, now that the PPE wave is over, what other collaboration should we think about at the South-South level? But to this day, even 9 months or into the pandemic, we still do not have the kind of North-South partnerships or South-South partnerships that would guarantee efficient supply chains, either on the technology side, on the commodity side, or even on the information generation and sharing side. So we still have a lot to do, and I'm hoping that this debate and this conversation brings to light some of these issues.
Thank you, Moka. That's super fascinating. And Thomas, so tell us about Open COVID-19. It sounds like an amazing project.
Hello, everyone. I'm super glad to be among you all. Thank you so much, Maria and Moka, for sharing your perspectives. I'm the co-founder of Just One Giant Lab. It's a very new NGO that was launched during the summer 2019. The goal of it is to create an alternative to institutional context to make science. The goal is to say that there are many underrepresented people in science and in technology development that needs to have a voice. And so being able to provide them an opportunity to collaborate with each other, providing them supports and resources, we should be able to see a diversification of the kind of approaches we can have for a specific scientific problem. And the way we act is not through a campus, a physical campus, but through a platform. So it's virtual, it's distributed, so that anyone in the world can participate. One thing we do beyond just providing a platform is we create also research programs with partners. We get funded by partners such as foundations or companies, and we create a framework dedicated to a specific problem where we invite the community to focus on. And that's what we did for COVID-19. We were among the first ones to launch an open science approach for COVID-19 back in the end of February. And the first focus of it was the lack of diagnostic tests. Back then, France was just experiencing the beginning of its wave, and even though we knew that it was coming, we had no way of saying what was the status of it, because we lacked diagnostic tests. You know, in just a month, I think we tested about 1,000 people, which is very few. And then the question was, obviously, we will be getting diagnostic tests in the future, but they will all be made by companies. We're using an IP-rich approach. And so the question is, how can we facilitate the propagation of good principle, good methodologies, and good technologies as fast as possible? Is to use an open source approach. And so we, with Jogo, we focus mostly on the creation of scientific and technological commons. And we did that for COVID-19, and we did that for diagnostic tests, but not only, because the community grew very fast from the few dozens we had at the very beginning, not a few thousands, coming from more than 100 countries. And we have more than 100 active projects in diagnostics, in treatment, in prevention, but also in basic understanding of the various functions or public health. And we have like a very high diversity of participants, ranging from, in fact, people working in public institutions, such as, being researchers or working in the CDC, for example, to students or professionals working as amateurs too. And to give you a few examples of what the programs has been providing, we support the community through the community itself. It's very important, since we're facing thousands of individuals, we cannot by ourselves manage that many people. And so the community is very heavily involved in the process of onboarding, monitoring, and reviewing the projects. And in fact, we do a review process to deliver also what we call macro grants to the projects, because you have to see it this way. Most projects, they are created by teams of individuals that have never met. So those teams have no official existence, they have no official organizations behind them. But how can we make sure that this momentum can be sustained and they can have resources to create a proof of concept for the idea? So we provide them with micro grants of up to $5,000, and in a very fast pace. It's less than a month between the time they propose a project, they get reviewed by the committee, and they get approved and receive the funds. And this way, we have been supporting more than 25 projects since March, and among them we have 4 diagnostic tests, for example, that are right now in the almost clinical phase. So 4 of them, they got now in semi-final of the X Prize international contest, which is where they're facing much bigger project done by corporations or academic laboratories, and even got validated partly by hospitals in Paris. So this is just an example to show that a community-based science that is community-based does not only work, but is actually scalable and efficient. And I really want to stress this, because I think the pandemic, as has been explained also by Maya and Moka before, is a very special context where we can explore new functions of society, and like new alternatives, new ways of understanding. At the end, we need to have an impact. How can this impact how can we perform that impact? And do we follow the usual rules, or can we invent new ones? And I think that the fact that we've seen such a beautiful reaction from the civil society, because somehow also our institutions were too slow to react, it shows that we have the ability to incorporate them more, and it just means that we have to also reinvent new frameworks. And research institutions have a hard time being able to collaborate with external communities. It's very hard. They don't have any tools for making this happen. So for us, our role is to provide that interface, to provide that alternative, and provide also a solution for projects that wouldn't be fit for a startup approach either, because they don't have a specific business model in mind. They are not looking at solving a problem because they can sell solutions afterwards and make a return on profits. It's mostly how do we de-risk R&D for problems that are going to be underexplored by traditional approaches.
Yeah, I mean, this is a very special moment, like you said, Thomas. And I mean, A, do you guys worry that this moment will pass and we'll sort of settle back into our old ways? And B, how do you sort of use this moment to make lasting change? I don't know, Maria, what are your thoughts on that? What are some of the kind of things that we can do to harness this moment for something that lasts?
Well, I think the points that have been made by Moka and Thomas are important to highlight. And that is that we're at an inflection point that helps us garner innovation, and that we have to be thinking of innovative ways of doing business. I don't know that in my world, where I sit, we've been doing partnerships for a long, long time. What's different here is the sense of urgency, because we've always been looking at partnerships, in our case, for example, with cancer, or when I worked in tuberculosis. But what COVID has done is it has compressed the time frame. And what I'd like to see is the sense of urgency and the compression of time and the sense of collaboration continue. I am worried that we will go back to the same, way as usual of doing it. Some things are not sustainable. Everybody has said how FDA, for example, got immediately into the act. And you, in your opening remarks, you commented on how they were able to come together, lower the hurdles, make sure we had PPEs. But I can also tell you that the FDA told us that they were tapped out. They couldn't continue that level of pressure. And I think all of us who have been working 24/7 on this can tell you that it has been brutal for trying to continue the momentum. So my hope is that we will learn from what we've garnered, that we don't lose the lessons, that the questions that Moka is asking of, can we go back to the old ways of distributing a vaccine? Can we find innovative ways of changing? I hope that that's the conversation that continues, because I know some things are not going to be sustainable, but some things need to become part and parcel of who we are. Changing ways of doing business, getting new partners involved, figuring out how to lower hurdles for things that are unnecessary, that became part of who we are or became part of the global health structure, simply because that's the way it was always done. So this is an important time, and I would like to capitalize on the lessons that we have learned, tap them, figure out how to package them, and base that on leap forwards of innovation. But I don't think that it can be done for everything. I think there are certain things that are going to be very difficult to sustain. And it will take, frankly, it will take political will. It will take commitment. It will take resources, both human and financial. And we shouldn't be fooled by that this has taken an enormous human, financial, and economic and social toll for all of us. And I'd like to be able to go back into a place where we're moving forward at a fast clip, at a steady clip, and we're not burning everything as we try and do it.
Yeah, do you guys have any thoughts on that? I mean, Moka, do you feel burned out? I mean, I think a lot of us who've been working during this pandemic have gotten a bit exhausted. It's sort of the pace feels unsustainable. How are you guys? How you and Moka and Thomas? What are you feeling right now in terms of your, emotional and energy level?
Well, it's a mixed bag. It's a very mixed bag. One of the most frustrating questions that I get right now is this a hoax? Is it real? And I think that question gets to the core of how much more needs to be done, right? Now, we have gotten immune to the statistics that we see on TV about the number of new rates, the number of cases and deaths, where death from COVID is becoming meaningless to global communities. And so I don't want to reemphasize what Maria said because it was so eloquently said. I'll do it a disfavor to try to even paraphrase. So the urgency around the need to sustain the new collaborative models and distribution models, I think it's clear. What I see as very key for sustainability is the ability for the media to change a little bit of the level of urgency around getting people to understand indeed what is happening in people's lives. I happened to travel to the US 2 weeks ago, and then I had to do a COVID test in order to come back to Kenya. It must be a PCR test and not an antigen test. So I got an antigen test at a Walgreens facility in Rochester, New York, boarded my flight, and landed in JFK, and I was told I could not board the flight. I needed a PCR. Now, nobody at JFK could tell me at 7 o'clock in the evening where to get a PCR test. It just happened that a flight attendant said the only place she has heard other people who have missed their flights is at an emergency room in Brooklyn. And I had to get a car from JFK to Brooklyn, and that was around 9 o'clock when I got there. It was unfortunately the first debate night, and I was in the emergency room in the US till 3 o'clock in the morning before I got a COVID test. Now, if that gives you any sense of where we are, then I came out of the hospital, actually the better part of the story, I came out of the hospital and I said, well, let me give myself the best chance of having food in New York City. And I went to Times Square, and all the restaurants in Times Square were shut down. Now, I share that story to say that until we start telling the real stories of how the pandemic has shifted life and the relationship we have with every aspect, travel, eating, then the perception of the hoax remains. And it puts a lot of pressure, emotional pressure on us as healthcare providers to now have to take on more responsibility of educating our customers. So patients come and say, well, I'm not sure. Donald Trump got cured in 3 days. Why are you asking me to remain in the house for 10 days? What is that treatment that Donald Trump had that you did not give us? Why are you seeing? So that is what we are dealing with right now. And then we have to explain to them why an antibody test is not good enough and they must do the $70 PCR test. So it's emotionally draining, and to the extent that there is a lot more information that is brought down to the family level, so people understand the relationship between their food, their wage, and the pandemic. We still have a long way to go, so that and so the conversation doesn't end at the policy level. It really now starts getting to the transactional level, and people start thinking about this differently.
So Thomas, it sounds like you guys had this enormous outpouring of interest and support early on, or maybe still now. And have you seen a drop off in that interest, and and what can you do to kind of keep it going, or is it just sort of inevitable that there will be a sort of fall off in this kind of thing?
Thank you, Maya. Yeah, you have to realize that a crisis is still a crisis, and even though, as Moka explained it very well, we got used to it, so we cannot call it a crisis anymore. We are not in crisis mode anymore, and when everybody got under lockdown during March and April, that was for us a massive moment of growth. And because never before people had attempted, in creating such a massive mobilization for doing open science in such a fast pace. We had to invent new rules and very fast. And so it's been a very intense period, and we also had to onboard hundreds of people every day, explaining them how this is going to work, where they can go to find what information or what people they can work with, etc. So it's been extremely intense, but I'd say we probably felt the same as any doctors, in hospitals where, I mean, there is no time, right? We have to do the maximum we can do, and we don't know what's going to be the outcome of this. We have to do our maximum, but the situation got smaller. We got deconfined, and for sure the presence, the activity decreased, mostly also because people that were able to pour energy into the system, into the projects, got back to work or to school. And so they had less time. So now what we see is projects are still, new project appears and projects are still being in development, but at much lesser activity. I would say about a third compared to April, for example. It's still a lot when you compare the numbers. I mean, we're talking about between like an average about 1,500 people coming to the platform every week, to interact. But what I see is because we were not ready, because we have to invent new ways of making such collaboration happen, especially for people that are not in a professional position to ask themselves this question, like, this is my job, so I have to do something. How can I build a solution that can actually work? So there is a lot of education, there is a lot of pedagogical tools to create, and this is being built up. This is being also built in collaboration with other initiatives, and I think COVID-19 has just been the use case to prove that this kind of approach is important, is necessary. Now we need the time to standardize the methodology, so that it can be used by other organizations, that we agree on the approach, that people are more aware of the kind of behavior they can adopt within those kind of systems. This is pretty new. The internet is not that new. We are used to collaborate. We need to talk on forums or on calls, but to do remote work at this kind of scale is pretty much new for all of us. Like we spend all our time on Zoom calls now, and that means that how do we sustain collaboration on the long run? This is also a very difficult questions to answer. How do we? I mean, it's also an opportunity, right? Because that means that then because the location becomes meaningless today. Thanks to that, it means that a lot more people are eligible to become a collaborator. You don't have to be in the same city. You don't have to be in the same building. And that for me is the most interesting part. Is we're redistributing the cards here, and I think we're going to be able to go beyond the trauma. And find actually resources in this kind of approach. For me, there is a profound inequality in how we attack a problem. And as I was saying, that we have underrepresented people that would actually to be able to have a voice and be able to contribute. Talking about students, for example. It's so hard for students have been completely ignored during the pandemic. We had so many students coming to our platform saying, I mean, I don't have anything to do. I'm lost. What's going with my life? And they could actually join projects and find other students, create teams, and feel empowered. And I think that students they deserve to be offered the opportunity to be able to work on impactful projects that matters to them. It's very, and it doesn't mean that it's such projects are around their vicinity, like within their own network. They have a small network. Their school have a potentially small network. So how do you make sure that someone who has no network, no social capital can find, a project that they can contribute to and can learn with? So I think this has been something that appeared to us because of the scale, because of the number of people that came to us, and then what were small signals to us because we had a small network became like large signals. Oh, we have to do something about that.
Fascinating. So that brings us to the next part of our program. We're going to open it up to folks out there listening, and I love the fact that we have people from all over the world. This is amazing. I'll start with the. Did you want to say something, Florian, before?
No, just go ahead. You can ask a question if you want. We have a few questions in the chat, and we have 15 minutes roughly to answer them. So, but go ahead.
All right. So this question comes from Cleophas, and who asks about the partnerships, the rider partnerships, Moka, that you have there. And Cleophas wanted to know, how's it working out with health providers, and how does the doctor-patient interaction happen when needed?
A very good question. The opportunity to engage riders was really one of those that, you know, we stumbled on by virtue of trying to solve the problem. The problem was with the shutdown of public transport systems, with the public agenda to promote telemedicine, what was necessary and required for equitable access to telemedicine. Now, in the first few weeks, when we set up our telemedicine services, we noticed that people who were calling in for the telemedicine services were highly educated, highly aware people. And we quickly noticed that in as much as everybody has access to a phone and could technically do a video call and could download an application, 95% of the population was unwilling to do that spontaneously. And so people started shying away from healthcare, not engaging their providers, because the only mode of healthcare that they were accustomed to was a physical interaction. And so by saying, throwing a blanket statement, use telemedicine, we realized that it is not syncing at many levels. Now, the notion of telemedicine assumes that you could have a virtual encounter, as we do have, but if there is also the component of how do you get the medicines to the person? How do you get payments back? How do you get lab samples from the person to the clinic? So it really forced us to kind of rethink about the whole logistics of healthcare, whereby 90% of people at home under lockdown, we are considered emergency services, allowed to go to work. Public transit systems are either not working or it doesn't make sense for them to work because people are not coming. So what do we do? And so we went to neighborhoods and we started speaking to riders and say, how could you partner with us to really help people come to us if they need labs, or if we call you, can you deliver to them? And so that conversation started with one group of riders in a rather, I would say, you know, the transition point between the Mathare slum in Nairobi and a very affluent slum, Lavington in Nairobi, right? So we're trying to see which one would, where would the momentum shift? And what we saw is that there was a universal need for people to talk to doctors during the pandemic. And so we trained the riders to use their phones, because many of the riders have smartphones. So we give them data, they go to the homes, and then they use their phones to connect us with the doctor. So it is not each person in their home using their phone to connect to us or downloading an app. It is our riders serving as the conduit. And so now the riders have been trained on how to identify homes with healthcare needs directly or through agents. And then they book the appointment with the rider, not with the doctor. The rider comes, initiates the conversation with the doctor. We do a teleconsultation. And then if there is a need for the patient to be brought in, the rider gets instructions to bring them in, or we send a medical car. Or if there's a need for a prescription, we prescribe, the rider comes and picks up the medication and goes to the home and explains to the person. And we realized that through that process, we had eliminated a lot of the barriers of access to telemedicine, in as much as on the surface, telemedicine seems like a very equitable platform for all populations. People to this day need to understand, would my insurance reimburse? How do I talk to a doctor? Is my privacy protected? What information can I share? When do I call the doctor? How do I talk on the phone with my doctor? So there's a need for massive public awareness globally, including Kenya, on how to talk to a doctor. In South Sudan, same organization, same process, and we're yet to get people comfortable talking to us over the phone. So it's really a massive issue that we're dealing with to talk about equitable access to telemedicine in its current form.
Andrew, may I ask a question of Moka?
Yeah. Go ahead.
Thank you. Moka, this is absolutely fascinating. What a fabulous job you guys are doing. Do you see that the families that you visit and the people that you visit after the rider has left, after they've had the experience, are they feeling more comfortable? Would they be willing to download the app and do it themselves? Or do you think that the rider is always going to be an important piece?
Very important question. What we are seeing with patients with chronic conditions is that after the initial encounter, they know a number to call. They now have some context as to the medical facility that is being treated. So we're getting a lot more inbound calls from the chronic patients to us after the first visit, right? And say, I need to get my medications. Can you send the rider? Or they'll call the rider because we give them a voucher or a booklet which has the rider's number, our customer service number, and they could choose one or the other. What we're seeing is that they have a strong preference of calling the rider to say, please don't forget to bring my refills, or please don't forget next Wednesday to take me to the clinic for my test. So we're seeing the rider as a critical intermediary, a trusted element, because if you will, what we're noticing is that there's a comfort level dealing with the riders, which many families have, because they see us as a clinic, me as a doctor, as they don't want to make a mistake when engaging with me, but they can afford to lay their issues to the rider, who then bring the issues to us. And it could be as simple as, well, you gave me medicines, but you remember the last time my child has been having diarrhea. Is that okay if I talk to the doctor about that? Right? So they are seeing the riders as trusted partners in this process. And so far, at the current scale of about 30,000 homes, we have not had an incident which suggests that we can sidestep the rider in the conversation. We do channel all of the communications as much as we can through the riders, obviously patient privacy limitations being respected.
Cool. And Thomas, is there any? You sounds like there's so much going on with your project there. Is there one particular initiative that you both are proud of, but you also think is sort of scalable or doable in other places, especially the developing world? Which one would you sort of pick? You're on mute again.
I have to get used to that. Absolutely. I think currently one of the major initiatives within the program that we are sure that can have an impact in the short term, not only in in developed countries, but also in developing countries, is a diagnostic test. I was speaking of not just any diagnostic test. I'm talking about tests that are much cheaper. We're talking about $5 to $10 per test. That doesn't require a PCR machine. So and takes less than an hour to get an analysis. So we really focused on tests that are easy to manufacture and distribute and to be used without the help without even the help of a professional to get the result. And why this is important? Because it means that once we are clinically validated by a public institution, be it in Europe or even in the US, that means that this recipe can be used by any company in the world to be replicated without royalties, because this is open source. And so it's as I was for example, is already being the case in Sri Lanka. One of the projects has been forked, so copied, if you want, in Sri Lanka, and is being tested into, with the Ministry of Health to see if it could be actually distributed more globally. And for me, so it's a double thing. We are pretty much used to open source in the software industry. Everything becomes so simple and cheap to make proof of concept, because you can use those bricks, things that have already been built before. But it's not the case yet in biotech. Biotech is extremely expensive, and it's expensive because it's complex. Also, it's much more complex than what is software. It's kind of like software, in the 70s, but it's changing. Biotech is becoming simpler. We have more tools, we have more knowledge, and so we see that our ability to prototype fast systems becomes better. And so open source is enabled. And I think that diagnostics tests use technology that are simple enough so that they can become open source. And we can see actually the creation of many more type of diagnostics tests, for many more diseases that are open source, and means that we'll have at our hand tests that would be extremely cheap and could be distributed and manufactured locally in a much better way. And I think this is very exciting, very, very, very exciting.
And that's an antigen test, is that?
No, it's an DNA amplification test.
Wow, cool. And Maria, what would you say was sort of one project you've been working on, or something that is sort of pandemic related that you feel like is worth replicating and has the ability to be replicated elsewhere?
Well, so there are a couple of things that come to mind. One of them is the massive amounts of information that we have garnered that we didn't have before. So creating a database that everybody can access to know, for example, what the preclinical steps are if you want to develop a therapeutic, or if you want to develop a vaccine. We really didn't have, we knew, certainly the NIH knew who they funded, who was doing the basic science, where we had the best animal models, who was doing clinical trials. But it wasn't in one place. You couldn't just say, okay, where do I go in the case of therapeutics? Where do I go to get preclinical trial tests done? So Group A would have one list, Group B would have another list, and we really didn't have an integrated international list, or at least the America in the United States list of people would say, oh, if I needed this tested, then I go to A, B, C, and D. Now we do, and we have it now in a repository that is based at the NIH, and people can go in and click in. So massive amounts of information that have been garnered to sort of put order of where things are and where things need to be found. So that's one thing that I think ought to be replicated. Hopefully we will not have anything like this in our lifetime. Not sure about that, but I hope. The key then is not to be scrambling to figure out where things are. So we want Thomas's group, we want Moka's group to be able to say, okay, where are the resources? That's done. Good, check, moving on. Where are the gaps? So for me, the most important thing in trying to create innovation is to figure out what question to ask to change the trajectory, either of knowledge or of care or of interventions. And the more we have things, the more organized we have them so that we know where to go, the faster we can get to where's the gap. And I think Moka has discovered where the gap was in terms of the relationship with the patient. Thomas discovered where the need was when he had that influx of people saying, where do I go? For us, when we were trying to develop the vaccines, and importantly the therapeutics, which is where most of our intervention is, we needed to know where the tools were. Where did we go to find the animal models? Where did we go to find the researchers? So creating that infrastructure can then pivot to the next major question was, for me, is very
Awesome.
Thank you for these insights. Thank you, everyone. I'm just jumping in because we're moving on to the next part of our program. Thank you, for you, sorry. I'll leave the floor to my colleague Camille now, who will introduce the next part of the conversation, and we'll be back right after.
Hello, everyone. So I think you'll be able to hear me. So thank you, Flo, for this introduction, and thank you all for this engaging conversation about collaboration in the health sector. So as you said, it's very important to harness the collaborative energy that has been deployed during this COVID-19 crisis, and to make sure it gets sustainable over the next few months. So we at Sparknews believe that it's important to shed light on social entrepreneurs who have concrete solutions to today's most pressing issues. And in the case of the health sector and the crisis that we're living in today, it's also very important to actually give the mic to those local actors on the ground who are also acting to find out solutions to today's health crisis. So now I'm going to ask the first entrepreneur to come on stage, because the idea is for her to pitch during 3 minutes in front of you and to present her wonderful NGO, which is called Climb for Albinism. So please do not hesitate to write down your questions in the chat like you did early on, and we'll take a 5 minutes time just right after her pitch. So if you have any questions, she'll be able to answer. So Jane, you're the co-creator of Climb for Albinism. Can you hear us?
Yes, I can hear you.
Yes, perfect, and we can hear you perfectly, so that's all good. There is a timer in the screen that you can see, so you have 3 minutes, Jane, and the floor is yours, and we are hearing you very well.
All right. So good evening, everyone. So my name is Jane Waithera, and I'm the co-creator Climb for Albinism. I'm also the founder of Positive Exposure Kenya, and I'm going to go straight to the point. And I'm going to give you a small story. When I was born, my mom was a teenage mother, and when she was in the labor room, before she could even see me come out, the midwife who was assisting her screamed and said, like, "What is that?" And the reason the midwife screamed was because I was born with albinism. For my teenage mother, she did not have any idea on what albinism is and what was wrong with her child. So this is a recessive genetic condition, and that was also coupled with the stigma that is societally constructed by the society. And as many of you may know, persons with albinism in Africa are a community of high alert, because we have to deal with our own health challenges, that is the skin care and eye care challenges that come by default because of albinism. On top of that, we have to deal with the society's stigma and misconceptions that go around it. And this is why projects like Climb for Albinism and Positive Exposure Kenya main vision is to change perceptions about albinism and how society sees people with albinism, in creating awareness, in promoting socioeconomic empowerment and welfare. And through the organization and through the projects that we engage in, we've been able to work via collaborations and co-creations with Making More Health to create a one-stop shop, an application called Albinism and I, that supports future mothers who, like my mother, would be stranded in the labor room, find information about albinism on their fingertips, on their mobile phones. And this has also come in handy because we've existed for 10 years, and COVID has taught us with the innovation that anybody around the globe can be able to access the information on the application wherever they are without us having to go to them. We've also been able to conduct remote community albinism awareness sessions through other Making More Health partners on the grassroots and with ourselves remotely. And we've been able to engage key opinion shapers like teachers, midwives, and administrators who come into contact with albinism at the first level in the community. The other thing we've been able to do collaboratively and based on other health publications that Making More Health has done is to create a resource on understanding albinism. And this resource has gone along with not just for persons with albinism in Kenya, but the global albinism community, because the facts are the same. It's just the contexts that are different. And through the initiative Club for Albinism, with support from Making More Health, we were also able to amplify the voices of persons with albinism at the highest point of Africa, that is Mount Kilimanjaro. And this was a symbolic way for us to show the society that there's nothing that we can't do. And we are grateful because through such collaborations and co-creations, we've been able to amplify the albinism issue, not just as a society and stigma issue, but as a public health issue. Thank you.
Thank you so much, Jane, for your inspiring pitch. I think it was crystal clear because we don't have any questions yet, but I think it was a 3-minute pitch, so people just get the time to understand and get a sense of what you said. I do have a few questions for you, Jane. Maybe the first one is, I mean, what are the main challenges for you while raising awareness about albinism in Kenya and maybe when you started the NGO?
So the main challenges, because you see, albinism is perceived as a taboo, or it's a bad omen to have a child with albinism culturally. So breaking those barriers where the community thinks you shouldn't exist, and you're trying to humanize this condition and showing them that it's just lack of melanin. So I think that whole barrier between the humanizing and the cultural perspective and being a cultural context here in Africa, I think that was one of the main challenges, and just starting the conversation. And you see, like when I was growing up, nobody ever spoke about albinism. I even never saw any other person with albinism until I was 18, because either the children are hidden or killed when they are born, or just they won't come out because of the stigma. So trying to penetrate an area that is already very dangerous, like, and you know, like right now the way it has changed is, besides all those issues, we also get targeted for killings. So the whole issue of safety and security is even as you do the work, and ensuring that future genes born with albinism don't have to go through the experience. So it's quite all-rounded, but the key one is also meeting the albinism specific needs, things like eye care, like glasses, and sunscreen that is with high sun protection factor. Those are like some of the main challenges that people with albinism face.
Thank you, Jane. And I know when we spoke together during the preparatory call, you told me that technology was a very important asset that you deployed just before the crisis, which was a perfect timing. So maybe can you come back on why it was so important? And I mean, I know you do partnership on the ground with schools and local NGOs. So how actually technology help you to actually deploy this partnership at a larger scale?
So you see, with technology, like I have explained before, like the work that we do is like life-saving humanitarian work. And for example, the last 10 years, we've been doing more community engagements physically. Like we go to this community, raise awareness, and move to the next community. And when COVID came, luckily we had just completed like working on the albinism and NIE application. And how this has really been helpful for us is because, for example, Kenya, they imposed cessation of movement. So we couldn't move from one town to the other. But what this application did is that people were able to still access our services and the emergency needs that they had about albinism without us having to travel to the ground. And I think for me, that was the biggest lesson. And beyond that, we've also been able to hold now like webinars, like what we are doing with our community ambassadors on the ground, who are our link to the community. So really, with or without COVID, because the work we do is essential work, technology is becoming the bridge for us.
Thank you. amazing work indeed, as some people are writing on the chat. I think Jane just left the discussion. So maybe just the time for me to introduce our next speaker, but thank you, Jane, if you can hear us, because I think we might have been last questions for you, but it's just the live session, so we'll just follow up. But thank you so much, Jane. And now I'm going to give the mic to Benjamin Mousnier-Lompré from Ipso Santé. And Benjamin, I'll let you introduce your amazing project, and you have 3 minutes again.
Thank you, Camille. Can you hear me? Yes. Hello, everyone. So Ipso is a network of primary care centers in Paris, in the Paris region, that we launched 5 years ago. And we are aiming at building a new model, offering better quality, cost efficiency, and accessibility to all patients. We currently operate 3 medical centers in Paris, with a team of about 100 persons, and we're covering close to 100,000 medical appointments per year. And as collaboration is the topic of the day, one of our specificities is that we are bringing together interdisciplinary teams, including, of course, medical doctors, nurses, and other medical professions, but also other profiles such as engineers or organizations, management experts. And I strongly believe that this characteristic has been a key success factor for us. Especially it enabled us to build new care approaches, developing in-house a lot of new tools, and make significant steps forward in quality and performance. One of our starting point was that the current difficulties of the healthcare sector are multifactorial, and they are related to such diverse dimensions as the evolution of medical needs and approaches, of course, but also issues regarding organization, management, relationship models, especially with patients, technologies, and so on. And all of these dimensions are very intricate. And you cannot solve complex multifactorial problems with a monodimensional approach. And even if it seems obvious, it is not that simple to make it happen, at least in the French medical cultural context. So when we talk about collaboration, it's not only a mutualization of various skills, but being able to make these skills really interact on problem solving. And only to this condition, we can take a significant step forward, and this is the difficult part. So once we identified that this interdisciplinary collaboration was a key success factors, we wondered about the cultural context and codes we needed to set up to make it happen. So maybe I could share a summary of the several points we had identified and worked on. First, it may seem obvious, but we needed to set to the team common values and collective objectives instead of individual objectives, and we selected people that would fit these values and objectives. Second, very important, we reduced hierarchy and brought maximum transparency to the group. So everything is shared, and we apply on a daily basis a simple rule. Everyone is entitled to participate to decisions that matter to them, and one person equals one voice. And this was very important to build trust, to reduce fantasies that someone is making decisions for you. Fourth, we value initiative and innovation, and effective collaboration demands to try different things, and people should not be focused on avoiding mistakes. So we try to build an environment where mistakes are accepted and not penalized, and it needs, of course, to adopt a specific management posture, but also to foster a culture of non-violent communication and feedback, to fight misunderstanding and mistake shaming. So we invested a lot in training people on non-violent communication. So to conclude, because my time is over, collaboration is very demanding, and it needs a framework to build listening and trust between parties, especially when we bring together people with different cultural backgrounds.
Thank you very much, Benjamin. Maybe I have a question. I mean, you started your own health center, so why would you say that it's difficult to implement such a collaboration scheme in traditional health center? What are the main barriers?
I'd say that there is a kind of individualist and very self-focused culture in the sector, at least in France, from what I know. For example, when someone mentions multidisciplinarity, one usually refers to make different medical professions work together, and it already sounds challenging. Working with a profession which comes from outside the medical sector sounds, I would say, weird and probably dangerous. And I believe that the first barrier is that you have to support the practitioners in operating a mindset change towards this, because they are very cautious when working with someone who comes from a different background.
All right. And you mentioned during your pitch that you have been collaborated with different experts. So it could be IT professionals or other type of doctors. Do you think about collaborating with other types of person now? It could be in the food sector or social services. What are the next ecosystem that you could reach out to?
Yes, of course. It's we are already working, for instance, with social workers. We've been for maybe 3 years trying to build common paths and to work together on patients with, for instance, social organizations or medical social organizations. And we're going now a step forward because we're starting to recruit social workers in the organization to help us make a step forward, especially when we're working with the most fragile populations.
Okay, very interesting. And because of the COVID-19 crisis, how are you managing to actually maintain the relationship with the patients? Because I know it's something that you're very cautious about. So, like, how does it work now that we can actually see our doctor from home through screen? How do you maintain these types of?
Yes, I think it's already been mentioned, but I think the crisis has accelerated a lot the adoption of technology, especially telemedicine. For instance, at Ipso, telemedicine was maybe 2 or 3% of our activity before the crisis, and at the heart of the lockdown, it was 70% of the activity. And even if now the lockdown is over, it's still more than 20%. So I think it has accelerated the cultural change, both for patients and for the practitioners too, because it lifted a lot of fears about that. Still, I think that people need a lot of physical relationship too, and it's something that maybe we underestimated in the first place. I think both about the relationship with the patient, but also in terms of team dynamics, because at first we thought that, okay, for us it doesn't change much because we're working in the medical centers, so we're still going out and still seeing each other, but we still had to reduce a lot of, we stopped a lot of physical meetings, and we tried to reduce the fact that people would meet in the rest areas, for instance, and we lost a lot of informal relationships, and inside the team, and also probably in the relationship with patients. It's probably a bit preliminary to draw conclusions, but when we look at, for instance, the teleconsultations, usually the time is shorter than a physical one, and it means probably that we are losing a lot of small informal things that may be important also in the taking care of patients. And I think we underestimated a bit this at the beginning, and we are only starting to wonder a lot about how to solve this problem, and we are currently invest a lot on trying to have more small attentions, both inside the team to all of the staff and also towards the patients.
Yes, reinventing the experience to see the doctors through a screen. Yeah, definitely. Well, thank you so much, Benjamin. Thank you for your speech. We shared your LinkedIn page on the chat if some journalist wants to reach out to you directly. All right, so it's time for me to welcome on stage our third and last entrepreneur, who is Anil, who is the founder of Carers Worldwide, and who will present you his wonderful NGO in a second. I think Anil will join on stage. Hi, Anil.
Hi, Camille.
So the floor is yours.
Greetings from Carers Worldwide. My name is Anil Patil. I'm the founder and executive director of Carers Worldwide. I'm also an Ashoka Fellow as well as a Making More Health Fellow. Carers Worldwide is a small international development charity focusing on achieving the recognition, support, and policy change for family carers in low and middle-income countries. By family carers, I mean that invisible army of individuals who care for sick, disabled, or elderly family members, often putting their own lives on hold to do so. We do not know how many carers are there globally, but we can be sure each one of us in our lifetime will be either a carer or somebody will be caring us. Sometimes we play both roles. Carers are often isolated, they feel lonely, they have their own health needs, experiencing anxiety, depression, and are excluded from education or the workplace. But much of this goes unrecognized. 84% of carers we work with are women, and more than 90% of carers are living with economic uncertainty. Carers Worldwide has been set up in 2012. Initially, we worked only with 250 carers in India to try and test our model. Since then, we have scaled up massively, expanded into Nepal as well as Bangladesh, and transformed the lives of more than 73,000 carers and their family members. We work in collaboration with the local partner organization to implement our model, which is addressing holistically about social, physical, emotional, and economic needs of carers, as well as lobbying to the local governments and achieving long-term policy change in the countries where we are working. Our close collaboration with the local organization and government meant that we have been placed to pivot, adapt our activities to support the carers and their families during this pandemic situation. As well as fear of the virus itself, the loss of access to healthcare, therapy, education has increased the concerns for carers and long-term futures for their loved ones. We recently conducted a survey which showed that carers in all our project areas have experienced mental health concerns since the start of the pandemic, with 55% reporting significant increase in stress and anxiety. 72% of carers have a reduction in household income since the start of the pandemic, and this is likely to continue to increase in foreseeable future. Making a More Health Fellow has been an immense support during this challenging time, as well as the financial support. It has meant that I have access to a broad network of other fellows, and we can work together to support and amplify each other's work in the health sphere. Moving forward, as we seek to build back better after COVID-19, that network of support and the opportunity it provides will be even more critical. Thank you.
Thank you so much, Anil, for this very clear pitch. So I do have a question. I think we talked about it during our conversation, but what types of jobs or complementary source of revenues do you provide to the carers you're working with?
That's a very good question, Camille. What we done is after this pandemic and lockdown, many people, many carers who were working, they lost their job immediately. So what we done is in collaboration with our local partner organization as well as other agencies. So during this pandemic, most of our carers, they knew how to stitch clothes. So we engaged many carers and cared for individuals like people with disabilities and people with mental health issues in stitching masks with local health guidelines. So that gave a source of income for carers and also kept them engaged rather than worrying about what is going to happen during this crisis. That is just one example I gave. And second example is many carers were engaged in making paper bags, simple paper bags, because plastics are banned. So local papers, newspapers, and we provided just half a day training, virtual training to many carers how they can make these paper bags, being at home and along with their caring responsibility. And we linked up with pharmacies, local medical shops. Instead of buying from shop, why don't you buy from our carers? So that gave another source of income. There are so many examples are there. That those are just two examples. We were able to engage carers and provide opportunity for them to earn certain incomes.
Thank you, Anil. Maybe another question for you. You told me that everyone at some point of his life will be a carer at some point. So would you say that this COVID-19 crisis has changed the way we actually see the caring? And do you think this will, I mean, just following the discussion that we had on the Roundtable, so is it something that could be sustainable?
Thanks for bringing that point, Camille. That was one of my realization. I realized that early during the journey of setting up carers worldwide, all of us on this planet, one or the other day, we all will become either carer or somebody will be caring us during our lifetime, or some people play both the roles. As a result of this pandemic, the importance of care has entered into the global spotlight. And this realization makes our work more relevant and critical than ever. And it is my hope that through collaboration, we will be able to emerge from this adversity in a better and fairer world for all. And you are absolutely right. And it is time to look at within our family, within our society, within our community. If people are unable to come out and able to see, just ask a simple question: how are you? Do you need any help? Those simple things takes a long way, really. And this situation, pandemic, really, in one of our survey, again, 72% of carers have experienced a significant increase in caring role. So because of this COVID, and there are almost 58% of new carers have come in because of pandemic.
Yes. Yeah, so definitely need also some more funds, and this is in political will, just as Maria mentioned earlier on. All right, thank you so much, Anil. So this is the end of our pitch session, and I will let the mic to Florian in a second for the closing remarks. But thank you to our three entrepreneurs. Thank you so much.
Thank you very much, Camille. Yeah, we're reaching the end of our webinar. So thank you everyone for your insights and ideas to build together a better future of healthcare around the world. There are still many challenges ahead, but some other actions can be put in place and amplified. And our speakers tonight have proven that collaboration is inherent to the human species. So by bringing the right forces together, there's still hope to get out of this pandemic quickly and to pave the way for more efficient collaboration in global health as a whole. And I'm sure, Manuela, you agree with me on that. If you want to add something to wrap it up, Manuela, if you're still here. Manuela is just on the stage now. But
It's working now?
hi, Manuela.
Yeah, sorry. I forgot to just press a button. No, I just want to say a few words. I want to thank all of you who participated today actively, and of course also all of you who listened. I thought we all got some good thoughts and insights. I just want to add at Making More Health, we work with a lot of social entrepreneurs and NGOs, people like Jane, Benjamin, and Anil, and we are very willing to put you in contact with our social enterprises, and of course also to give you more details if you're interested. So don't hesitate to get in contact. And yeah, thank you. That's what I want to say.
Thank you, Manuela. Yeah, thank you all participants for joining us. Andrew, Moka, Maria, Thomas, Anil, Jane, Benjamin for inspiring us. And also I'd like to thank the Sparknews team that's behind the screens there. Audrey, Camille, Agathe, Pingshuan, and Antonin. Just a reminder that this webinar was the first of a series of more webinars, or we like to call them digital learning expeditions, but yeah, we need to be flexible, that will focus on health. So there'll be more webinars coming by the end of the year and throughout 2021. They will focus on how to reduce healthcare costs, also how to secure access to primary healthcare for all, and how to better manage long-term care and illnesses. Of course, we'll make sure that you're invited to these upcoming sessions, and don't forget to invite your colleagues that I'm sure are pretty busy at the moment covering the pandemic, but we'd love to have them here to discuss with them as well. And in case you didn't get to see the whole webinar, you can still catch up with the upcoming replay that we'll be sending in the upcoming days. I hope you enjoyed this webinar as much as we did. So please take care and see you next time. Goodbye.